Welcome back to the deep dive. Today, we're really digging into the absolute foundation of medical knowledge.
We are.
We're taking a high-density, very targeted journey through core pathological principles. I mean, these are the concepts every medical learner has to have mastered before they even think about stepping into a clinical setting.
That's exactly right. We're sort of treating this deep dive as a dedicated review session. We're going to synthesize the highest yield nuggets from some key pathology review material.
Okay.
And our goal isn't just, reciting definitions. It's about recognizing the patterns, really understanding the mechanisms, and connecting that basic science of cellular injury to the complex systemic disorders you're going to see clinically.
So it's about building from the ground up.
Exactly. We need to structure these dense concepts clearly, moving from, let's say, the microscopic language of the cell all the way up to system-wide failure.
All right, let's unpack this language then, starting with how cells adapt to stress. When a cell faces chronic environmental pressure, it adapts by changing its size or number. Let's start with that classic distinction that, well, it trips a lot of people up. Hypertrophy versus hyperplasia. What exactly is the difference, and why do they so often happen at the same time?
So the core distinction is actually pretty simple. Hypertrophy is an increase in the size of individual cells.
Just the size.
Just the size, not the number. Think of muscle cells responding to weightlifting. Each cell gets bigger to handle the load. Hyperplasia, on the other hand, is an increase in the total number of cells. It's usually driven by hormones or some kind of chronic irritation.
So if the cell is non-dividing, like a cardiac myocyte, it can only undergo hypertrophy then?
Precisely. That's exactly why cardiac enlargement in, say, hypertension is pure hypertrophy.
But in organs with dividing cells, you're right, the processes often coexist. The classic example you see on tests is the pregnant uterus.
Yeah.
Its massive physiological enlargement requires both smooth muscle cell hypertrophy, the cells getting bigger, and hyperplasia, making more cells to accommodate that growth. That's a very clear distinction. Okay, now let's look at the other side of the coin, the spectrum of decreased cellular production or size. So we have aplasia, hypoplasia, and atrophy. Aplasia sounds pretty final.
It is. It's the most severe deficiency. Aplasia is the complete failure of a cell population or organ to develop at all.
At all?
If it happens early in development, we call it agenesis. The organ is just completely absent. Later in life, it can mean the permanent loss of precursor cells, which is devastating. Think certain types of severe bone marrow failure.
And hypoplasia?
Hypoplasia is just less extreme. It's a partial, incomplete development or decreased maturation.
Yeah.
You often see this in specific genetic syndromes, like with the gonadal structures in Turner or Klinefelter syndromes.
And atrophy is different because the cells were there, and then they got smaller.
Exactly. Atrophy is a decrease in the mass of an existing tissue or organ because of a decrease in the size or number of pre-existing cells. It's triggered by things like disuse, loss of endocrine stimulation, or just aging.
Okay, so what's the mechanism?
And here's where it gets really high yield. The degradation of cellular components in atrophy is actively mediated by the ubiquitin proteasome pathway.
Wait, tell me more about that. Why is that pathway so important here?
Well, because it shows that atrophy isn't just passive shrinking, it's an active, very regulated process.
Okay.
Ubiquitin molecules literally tag specific proteins inside the cell proteins that are damaged or just not needed anymore because of the lower metabolic demand. These tagged proteins are then shuttled to the proteasome.
Which is like the cell's demolition crew.
The cell's demolition and recycling crew, yeah. It breaks them down into amino acids.
Yeah.
This controlled demolition is what reduces the cell's overall mass.
That really sets the stage for the ultimate pathological failure, cell death. We absolutely have to dedicate time to the most crucial comparison here, necrosis versus apoptosis.
This contrast is foundational.
Yeah.
You have to know this. Necrosis is always pathological. Always. It's sudden, it's messy, and it's typically caused by a gross, irreversible injury, like severe ischemia or hypoxia. Crucially, it involves many contiguous cells. The cell contents spill out, and the body mounts a marked inflammatory reaction. It's a passive process.
And the visual marker, say, for test purposes?
The DNA degradation in necrosis is totally haphazard, irregular. If you were to run an electrophoresis gel, you'd just see a smeared pattern, a smudge.
Okay, a smudge. And apoptosis?
Apoptosis, conversely, is tidy. It's programmed cell death. It can be physiological or in response to more subtle damage where the cell decides to, well, self-destruct. It involves single cells. The cell membrane stays intact, forming these little apoptotic bodies.
And no inflammation.
And critically, No inflammatory reaction. It's a cleanup job.
So what's the mechanism for this clean, almost surgical death?
Apoptosis requires energy and gene expression. It is an active process. The DNA cleavage is specific. It happens between nucleosomes, which gives you these regular, predictable fragments.
And that gives you the different gel pattern.
That gives you the clean, multiple-banded electrophoretic pattern, the characteristic laddered pattern. And the intrinsic pathway is central here. When the cell senses damage, anti-apoptotic proteins like BCL2 are lost, which increases mitochondrial permeability. The cell then releases cytochrome C into the cytoplasm.
And that's the trigger.
That's the trigger. It activates the crucial enzymes, the caspase, specifically caspase-9, and that leads to the whole cell being dismantled from the inside out.
That really drives home the difference, doesn't it? It's a system crashing versus a system performing a controlled shutdown. Let's transition into section 2, inflammation, the body's immediate and delayed response. When acute inflammation starts, leukocytes have to perform this precise sequence of movements. How do they navigate that capillary wall to get to the site of injury?
It's a highly regulated process. First, they have to slow down. That's rolling, which is mediated by selectins. Then comes adhesion. This is where integrins on the leukocyte surface switch to a high-affinity state and bind really strongly to Ig family adhesion molecules on the endothelial lining.
They lock on.
They lock on. After that, they perform transmigration, or diapedesis. This movement across the vascular wall is critically mediated by a protein called PCAM1.
PCAM1.
Yeah, and it's expressed on both the leukocyte and the endothelial cell junctions.
So adhesion locks them down, and PCAM1 is basically the exit ramp. Once they're out, they need a kind of chemical GPS. What are the key chemotactic factors that draw those neutrophils in?
Chemotaxis is that directed movement toward the chemical gradient of the injury. Two really high-yield factors are derived from arachidonic acid metabolism. First, leukotriene B4, LTB4, a very potent chemotactic agent for neutrophils. Second is HEDT, which is derived from 5-HPET and is also a powerful neutrophil attractant. I mean, there are others, like bacterial products and C5a, but LTB4 and HEDT are often isolated in exam questions because of their lipid derivation.
Got it. So once the neutrophils arrive, they're ready to kill. We need to distinguish between the body's main oxygen-dependent killing system and, well, the backups.
The primary system is a really effective oxygen-dependent myeloperoxidase halide system. It requires the production of hydrogen peroxide HRO via the respiratory burst.
Okay.
Then the enzyme myeloperoxidase, or MPO, uses a halide-like chloride to convert that HRO into hypochlorite, which is basically bleach. It's incredibly efficient at killing ingested microbes.
And if that fails?
If the oxygen-dependent system fails, the body falls back on the less effective oxygen-independent systems. These rely on preformed proteins like lysozyme, lactoferrin, and defensins within the phagolysosome.
And this detail is absolutely crucial for understanding specific defects, right? Particularly chronic granulomatous disease.
Absolutely. Chronic granulomatous disease, or CGD, is typically an X-linked deficiency. The gene codes for a component of NADPH oxidase activity. What happens is the phagocytes can ingest the bacteria, but they can't mount the oxidative burst to produce the necessary HO.
So they can't make the bleach.
They can't make the bleach, and this results in these persistent chronic infections.
And here's where that high-yield clinical association comes in. It primarily affects specific bacteria. Why are catalase-positive organisms like Staphylococcus aureus the main culprits in CGD patients?
That's the paradox, isn't it? Catalase-positive organisms produce an enzyme that destroys the small amount of HEOUros they produce themselves. So since the CGD patient's phagocytes can't make their own HEO because of the NADPH oxidase deficiency, they're left with zero substrate for the myeloperoxidase system. The result is failed killing.
But catalase-negative organisms don't do that.
Right. Catalase-negative organisms leave their HO lying around, which sometimes allows the patient's MPO system to still work, even if just a little bit. It makes those infections less common.
That is a perfect example of connecting a genetic defect to a clinical pattern of infection. Speaking of chronic patterns, let's quickly touch on granulomatous inflammation before we move to genetics. What defines a granuloma morphologically?
A granuloma is a defensive mechanism. It's for fighting indigestible, persistent things like certain fungi or mycobacteria. Morphologically, it's a tight nodular collection of specialized macrophages. We call them epithelioid cells.
Okay.
And they're typically surrounded by a rim of lymphocytes. A hallmark feature is the presence of multinucleated giant cells, which are just fused macrophages.
Which giant cell should we specifically associate with tuberculosis?
That would be the Langerhans giant cell. It's characteristic of case-eating granulomas, where the numerous nuclei are arranged in this very distinct horseshoe or ring pattern at the periphery of the cell.
Fantastic. Let's jump into section 3, the complex enzyme-driven world of metabolic and genetic disorders. When you're reviewing lysosomal storage diseases, the information can be so dense, but we need that high-yield triad: the disorder, the deficient enzyme, and the accumulating substrate.
Let's lay out the three most common ones. First, Tay-Sachs disease. That's a deficiency of hexasaminidase A, which leads to the accumulation of GM2 ganglioside.
Yeah.
Then you have Gaucher disease, a deficiency of glucocerebrosidase, causing glucocerebrosidase accumulation. The Gaucher cells, under a microscope, they often look like crinkled tissue paper because of all the stored lipid.
And the third?
And finally, Niemann-Pick disease, a deficiency of sphingomyelinase, resulting in sphingomyelin accumulation. You'll commonly see these as foam cells.
And when we're looking at glycogen storage diseases, which one has that really profound cardiological impact?
That's Pompe disease, or type 2 glycogenosis. And it's unique. It's the only glycogen storage disease that is also a lysosomal storage disorder.
Ah, okay.
It involves a deficiency of the lysosomal enzyme Iwa-4 glucosidase. The accumulation of glycogen causes this severe, really striking cardiomegaly and muscle hypotonia. It leads to early death in infants, usually from heart failure.
Let's pivot to two massive single gene defects. First, cystic fibrosis, or CF. We know it's autosomal recessive, but what's the specific genetic mutation that causes 70% of cases, and how does that manifest clinically?
Right, CF is caused by a mutation in the CFTR gene, which codes for a crucial chloride channel protein. The high-yield mutation you have to know is the F508 deletion.
Delta F508.
Yep. It's a deletion of 3 base pairs that code for phenylalanine at position 508. This specific mutation impairs the folding and trafficking of the CFTR protein, so it gets degraded before it even reaches the cell membrane.
And the clinical result is the failure of proper chloride transport.
Exactly. And that leads to this increased viscosity of mucus everywhere in the lungs, the pancreas, the reproductive tract.
So that high viscosity is what leads to the chronic pulmonary disease, the recurrent infections, especially with Pseudomonas aeruginosa, and the pancreatic insufficiency.
Correct. And the diagnostic test is, of course, the sweat chloride test. Because that CFTR channel is defective, chloride can't be effectively reabsorbed from the sweat duct back into the cell, which results in really high chloride concentrations in the sweat.
Makes sense. Next up, phenylketonuria, PKU.
PKU is a failure to convert phenylalanine to tyrosine. It's due to a mutation in the phenylalanine hydroxylase gene. If you don't treat it, the accumulation of phenylalanine is severely neurotoxic. It causes intellectual disability.
And the essential clinical takeaway here is about the timing of the screening, isn't it?
It absolutely is. Newborn screening must be performed after the baby has ingested protein for at least 2 to 3 days. If you test too early, you can get a false negative.
Why is that?
Because the maternal metabolism keeps the infant's phenylalanine concentration normal right after birth.
That detail about timing is often the difference between getting a question right or wrong. Okay, let's move quickly through section 4, hitting the highest yield points across key clinical systems. Let's start with vascular pathology and the mechanism of atherosclerosis.
The dominant theory is the reaction to injury hypothesis. The primary event isn't just lipid accumulation, it's injury or dysfunction of the arterial endothelium itself.
Caused by things like high blood pressure, high cholesterol.
Exactly. Hypertension, hypercholesterolemia, toxins. Once that endothelium is dysfunctional, its permeability increases, which allows monocytes and LDL lipids to enter the subendothelial space.
And what happens when they get inside?
Well, the monocytes become macrophages, and they just start gobbling up the lipids, forming foam cells. Those are characteristic of the early fatty streaks. At the same time, adherent platelets and the endothelial cells release potent growth factors.
Like PDGF and FGF.
Platelet-derived growth factor and fibroblast growth factor, yes. These mitogenic factors stimulate smooth muscle cells to proliferate and move from the media into the intima, which leads to the formation of the fibrous cap and eventually the complex atherosclerotic plaque.
And when this disease weakens the vessel wall and it leads to an aneurysm, where is the most common location for an atherosclerotic aneurysm?
So while aneurysms are these localized dilations of vessels, the vast majority of atherosclerotic aneurysms occur in the descending aorta, specifically the abdominal aorta, usually below the renal arteries.
Okay, shifting gears to hematology. Let's compare two crucial types of anemia: megaloblastic anemia and anemia of chronic disease.
Megaloblastic anemias, caused by B12 or folate deficiency, are defined by impaired DNA synthesis. This leads to these large abnormal cells. It's a macrocytic anemia.
An anemia of chronic disease.
ACD is different. It's caused by systemic inflammation where the body basically sequesters iron. The high-yield lab pattern you're looking for here is low serum iron, but crucially, it also has a low TIBC, total iron binding capacity.
And that's the key.
That pattern, low serum iron plus low TIBC, immediately distinguishes it from iron deficiency anemia, where the TIBC would be high.
That comparison of TIBC is the key discriminator. Now, a quick high-level contrast between acute and chronic leukemias.
Okay. Acute leukemias are characterized by a predominance of blasts, these immature, poorly differentiated cells in the bone marrow and peripheral blood. They're rapidly progressive and are the most common cancer in children.
And chronic?
Chronic leukemias involve more mature-looking cells. They proliferate slower, and so they have a more indolent, prolonged clinical course. They typically affect adults.
Let's touch on cancer genetics. We mentioned that P533 is a critical tumor suppressor, which oncogene is amplified in neuroblastoma and in some particularly aggressive breast cancers.
Right, so the P533 tumor suppressor gene is associated with Li-Fraumeni syndrome when it's inherited in a defective form, predisposing to all these early onset cancers. The oncogene you're thinking of is NMIC, which is amplified in neuroblastoma, and HR2NO, also called ERBB2, which is amplified in certain breast cancers and often correlates with a worse prognosis.
And it's so important to know the difference between a tumor suppressor like P533 and an oncogene like NMIC or AR2NU.
Essential.
Finally, let's wrap up our systemic tour with a few critical endocrine high points. Let's start with Cushing syndrome.
Cushing syndrome is the result of prolonged elevated circulating glucocorticoids. And while it can be endogenous, the single most common cause in clinical practice is the administration of exogenous corticosteroid medication.
And the clinical picture is pretty unforgettable.
It is striking, yes. Central or truncal obesity, moon facies, skin atrophy with these purple striae, hypertension, and elevated blood sugar because of cortisol's gluconeogenic effects.
And the classic hyperthyroid disease, Graves' disease. What makes it unique compared to other causes of hyperthyroidism?
Graves' disease is hyperthyroidism from an autoimmune process. It's a diffuse toxic goiter where stimulating antibodies are produced against the TSH receptor. It's more common in women associated with HLA-DR3 positivity.
But the unique feature?
Its unique feature is the striking exophthalmos, the protrusion of the eyes. And that's caused by autoimmune inflammation and edema of the orbital tissues. And it's often independent of the level of thyroid hormone elevation.
And our final endocrine emergency from the source material, Waterhouse-Friderichsen syndrome. What pathology defines this acute crisis?
This is a devastating acute condition. It's defined by massive, usually bilateral adrenal hemorrhage.
And it's usually secondary to an infection.
Most frequently, yes, secondary to overwhelming systemic bacterial infection. Classically, meningococemia. The clinical presentation is rapid, leading to acute adrenal insufficiency, severe hypotension, and widespread clotting activation disseminated intravascular coagulation, or DIC. The severity of that acute loss of adrenal hormones often leads to rapid circulatory collapse.
Wow. We have truly covered a massive amount of ground today. From the active mechanisms of atrophy and programmed cell death through the detailed steps of inflammation, specific defects like CGD, and connecting those genetic faults to systemic pathology, and ending with crucial endocrine patterns.
Yeah.
The goal was to provide that high-density summary, making sure we highlighted the mechanism behind every single pattern.
And that integration is the most valuable part. So to finish strong and maybe test that integration, let's use a brief case vignette that requires connecting several of the pathological principles we've just talked about.
I'm ready. Let's do it.
Okay. A 45-year-old man with a history of chronic heavy alcohol consumption presents with jaundice, marked abdominal swelling, which is ascites, and generalized muscle wasting. His lab work shows hyperbilirubinemia, significantly low albumin, so hypoalbuminemia, and mildly elevated liver enzymes.
Yeah.
What is the most likely pathological finding in his liver, and what are the dual mechanisms that are leading to the hypoalbuminemia and the ascites?
And for you, the listener, just take a moment to integrate that presentation. The alcohol history, the wasting, the jaundice, and ascites, it points us directly toward a specific type of chronic injury.
The most likely diagnosis is alcoholic or lanic cirrhosis. And the mechanisms for his clinical state are a perfect summation of our topics.
Lay it out for us.
Okay, 1. The liver damage has impaired its synthetic function. This causes the hypoalbuminemia, the low serum protein, which decreases the plasma oncotic pressure and contributes to fluid shifting out of the vessels.
Okay, that's half of it.
And two, the ascites is driven both by that low oncotic pressure and by the scarring in the liver, which increases portal venous pressure. That literally pushes fluid into the peritoneal cavity, and it's all compounded by the kidneys retaining sodium and water.
That perfectly illustrates how fundamental cellular damage progresses all the way to systemic failure. Understanding the why albumin synthesis is decreased is the key to understanding that clinical picture.
Precisely. Keep connecting the dots between the microscope and the patient, and these fundamental concepts will really solidify. Keep digging and keep applying these high-yield facts.